Thanks for coming. I'm so amazed that there's people here, especially considering we have such a busy day today in the school. There's another speaker that's this afternoon and some other stuff that's going on. So thank you for coming and thank you for showing up so early to start your Tuesday. So I'm Sabrina. I'm a person that works in the School of Nursing and also at the Center for Health Services and Policy Research. And I'm going to talk a little bit today about some of the work that I've been doing. But before I start, I just wanted to introduce a couple of people who are here with us as scholars, visiting scholars. So one is Tia. Tia Liang is from China. She's from Fanshan University and is a nurse teacher there. Is that right? You're a nursing teacher. And she's been very interested in looking at what we're doing here in terms of the patient medical home, because they're also implementing the patient medical home in China. So she's here with us until October, and then she'll be heading back to Fanshan University. And then the other person I wanted to just introduce you all to is Dr. Janice Ferreira. Is that how you say your last name? How do you say your last name, Ferreira? And she is from Brazil, family physician from Brazil, and also has a PhD in public health and has been doing some work in the area of primary health care and just recently arrived, but only with us for a short period of time until the end of June. So those are our visitors in the School of Nursing. Okay, so I think I know almost everyone in the room. There's a couple people that I don't recognize. So maybe, I don't know if you all know each other, but maybe you could just introduce who you are.
I'm a retired nursing instructor from here, and I come to keep my brain working to know what's going on.
That's great. Thank you. Welcome.
Wendy Hall, professor at the school.
Raluca, I am an MSN student, just finished my first year. Jillian Harding, and I teach in the nurse practitioner program.
Okay.
I am Maura McPhee. I'm a professor at the school.
Hi, Fuchsia Howard. I'm an assistant professor here at the school.
Elizabeth Saywick, a professor and director of the School of Nursing.
I'm Sandra. I'm a clinical assistant professor.
I'm Denise.
I'm Lindsay. I just finished the undergrad program.
Oh, great. So you're graduating or you have graduated?
I'm technically finished. The graduation date is May 31st. So,
Okay.
Yeah.
Yay, you're finished classes. Congratulations. Wow. Okay, so here we are. And oh, there's some people online. I should see who is online. Oh, there's a whole bunch of people. Did the people online want to introduce themselves, or is that too difficult
I
to do?
muted them so that
They're
there isn't
muted.
any feedback on the mics.
Okay. Okay. All right. Sorry, people online. You are muted. But you can always type in your questions afterwards. So I'm going to go ahead with the presentation. Hopefully you can see the screen and type your questions in. And we have Marilee Hughes here who will be able to ask the questions to us all. Great. Okay. So this is all about primary health care, and it happens to be let's see, since 78. So yeah, 40, 50 years? How many years has it been? I can't do math. 40 years. 40 years since Alma Ata, WHO came out in 1978. And they're actually, I think today is the deadline to give the WHO feedback back about the definition of primary health care. So if you wanted to go on their website, you're welcome to do that, but I think their definition still stands in terms of primary health care, and this is really trying to highlight what nurses have done and what they contribute matters. Is that good? Okay. So I just thought these are the kinds of things that I would cover today. So a little bit of a definition, so we're all on the same page, and then some examples of where nurses are making differences and based on some of the work that I've done. So this is the definition from the WHO, so you can see that it's very broad. And really, the work that I've been doing is looking really at the first level of contact for individuals, families, and communities. And it's really, I'm looking at it more in terms of a place of care and a service delivery versus a particular philosophy to care. So all of the work that I've done is really being in the community. So this is, I'm going to draw on some experiences, and some of the experiences that I have are because I'm the co-chair for this strategy for patient-oriented research, primary and integrated healthcare innovation network. And you can see that this is a network of networks across the country. And in each of the little network nodes, there's 3 different kinds of leads. So there's clinical leads, policy and decision maker leads, and then the research leads. And so I am a co-chair of the whole entire thing, as well as am the science lead in British Columbia. And so, of course, we work a lot with patients in that as well. So as part of the Primary and Integrated Healthcare Innovation Network, we run a data platform in order to try to basically engage clinicians and also to do work in primary care. So it's not that we don't like to do qualitative work. We absolutely love to do mixed methods and qualitative work. And then this is a platform by which to try to capture some of the clinical data that's generated in electronic medical records, and then to put them together so that we can use them for analysis purposes. So the data platform that's used is the Canadian Primary Care Sentinel Surveillance Network, and it essentially draws data variables and elements out of electronic medical records. So at the moment, there's about almost 1,250 practices that are participating, 1.6 million patients across the country. And in British Columbia, we have about 81,000 patients in the database. And we have a practice-based research network here in British Columbia. And it was originally started with some funding from the Public Health Agency of Canada, and currently sits as a data platform, and it's mostly being funded now through the Strategy for Patient-Oriented Research, Primary and Integrated Healthcare Innovation Network, as well as there's some other sources of funding. And then it has strong partnerships with different colleges across Canada, as well as Queen's and other universities. And this data extraction method, there's also nurse practitioners that participate in here. So any basically physician or nurse practitioner, someone that has a patient panel that they're responsible for, can participate in the system. So the purpose of the Primary and Integrated Healthcare Innovation Network is, as you can see, to support evidence-informed transformation of the primary care home, and where the primary care network can play a central part of the delivery and coordination and integration into the healthcare delivery system. And so if you're interested in some of the work that's been going on, then there's some information there. And we have a Twitter handle, which I have other people that tweet for me. So we also, through this work, in British Columbia, we've put together an advisory committee, and the ones that I've circled in purple is really meant to highlight for us here that nurses have been involved and are involved, and are strong contributors to the work of the primary healthcare network. here's some examples of supported projects, and this is really to show you the range of projects that this page is showing you ranges of projects that I've been involved in and how there's been engagement with the different health authorities as well as the different divisions of family practice. And within the different divisions and health authorities, there's various nursing folks that have been involved in these different projects. So the one that is pretty interesting is that we're going to go live for September 1st is this one with where it says the lead is Douglas Kingsford with Interior Health. So this is the health authority wanting to look at data and patient flows and partnering with Kootenai Boundary Division of Family Practice. And so there's a lot of, I guess, back-end work that has to go on to have health authority data linked to electronic medical record data in that particular division. And so we're going to use different analytic solutions. So one is, the health authority can extract their data, and then CIPSIN will be used to extract data from the electronic medical records in the Kootenai Boundary Division. And then we will deposit those data sets into Population Data BC, where it will be linked. And this is all being done not as a research project, but really as a quality improvement project. So there's a lot of things that need to go on with governance and common program agreements, et cetera, et cetera. And then the idea is to slowly try to see if people would be interested in doing more research and using the data that's data set that's being put together for secondary use. So this then presents a really great opportunity for nurses working in the system to be doing things in terms of program planning and resource allocation, et cetera, because you'll be able to see patients and how they move across the primary care, and then, of course, all the health authority stuff, which includes home care, public health, hospital, et cetera, et cetera. So it's a very interesting project, both on the program and implementation side, but also on the governance side, and then the informatics side as well. So that one is, supposed to go live on September 1st. So I'm working hard to try to get that done. And then another thing I think that really presents an opportunity for nurses and nurse practitioners is looking at the implementation of quality improvement tools into practice. So this is the second one, the implementation of Inquire and the data presentation tool. And so that really can help clinicians look at their data in primary care because they haven't really had a chance to look at it very well. So they typically can put data in, but then it kind of gets lost and, you can only kind of see some things. But with these quality improvement tools, you can really see how you look compared to the site that you're working in compared to the network itself. And then once we implement it across Canada, then you would be able to see what it looks like. How does this site compare to the other practice-based research networks? And the idea is to provide the information in such a way that, one, it helps the clinician at the point of care and practice, but also it spurs on the imagination of people who are wanting to do more research to really try to do things that are sort of at a pan-Canadian level. And so that's also a pretty interesting project. And I'll talk about this one in a bit, the one with Annette Garm, where she's bolded. I just have bolded people's names because they're nurses in particular, working in the different health authorities to highlight the different work that's been going on and some of the contributions that nurses have made. So these are the other examples of the supported projects through the Primary Healthcare Research Network, which is the BC node of the or PICI. And you can see there's a bunch of different nurses and how they have been contributing to the different kinds of projects that are going on. So in particular, Leanne Curry here at the School of Nursing has been contributing as part of the BC team to policies and programs that connect primary health care, social services, and public health. And then also, you know, we have some connections now with UBCO through Nellie Elke. And Jennifer Korishko, who's also here in the School of Nursing, has been working on some stuff in terms of palliative care and how you might increase the amount of support available to people who would like to stay in their homes during the palliative stages, and integrating paramedics as another kind of source of support for people. Oops. Okay, so one of the sort of contributing examples I wanted to just talk about is the collaboration between primary care and public health. So this is a project that was done across British Columbia, Ontario, and Nova Scotia, and these are the kinds of things that we did. And so, you know, we did a whole bunch of stuff. We did environmental scans to understand what does it look like in British Columbia and the other three provinces in terms of collaboration between primary care and public health. We did a scoping literature review to see what is it saying in the literature. And we did interviews, over 70 interviews, and then we did 10 case studies. And so one of the outcomes of this is that we were able to create a toolkit of collaboration between primary care and public health, and that's available and can be used as a teaching resource for students and other primary care and public health professionals. And what was really clear was the amount of work that nurses are doing in terms of collaboration between these two different sectors. So this was a ecological framework that was developed through this project to understand what collaboration looks like in primary care and public health, and that successful collaboration really is a product of interpersonal collaborations, intrapersonal, interpersonal, organizational, and systemic factors, and that nurses are working at all of these different levels, mostly at an intrapersonal and interpersonal and organizational levels, as they are the glue from those different organizations to really make the collaboration work and to strengthen the healthcare system. So what were the areas where nurses are facilitating collaboration? What was common across the three different provinces are these areas, and you know, it's not kind of rocket science, and it's probably not new to us, but I think being able to uncover this and really highlight it for the rest of the world is really important. So those are some areas, and this is all within the scopes of practice for undergraduate nurses coming out of our program, so they clearly have a place to strengthen our program. And then what was common, particularly in British Columbia, was the work that was being done in terms of Aboriginal health and also mental addictions, in terms of the collaboration between primary care and public health. So another example is a project called the CARES project, which is run out of Fraser Health Authority. And this is just a picture of a person who is participating in the program and what she has to say about not wanting to be frail. So what is frailty? I think it's really, it's kind of a little bit wide open at the moment. There's no real good conceptual definition of what that is. And there's clearly unmeasured heterogeneity as people get older. So what this chart is showing you is that mortality goes up as age also increases, but that it becomes pretty heterogeneous in terms of how that happens. And it is curvilinear, it's not a direct relationship. So there's clearly things that can be done to what we call concentrate the mortality morbidity, so that you're living more of your life not being frail, and then you die, right? So a good example I always think about is Ed Whitlock. So I run marathons, and Ed Whitlock runs marathons, and Ed Whitlock is, I think he's in his 80s, and he can run a marathon probably faster than me. The guy is super fast. And so Ed Whitlock basically ran for most of his life, and then one day he just dropped dead. And so that's what I'm talking about when I'm saying concentrating the morbidity, so that you're not in a long period of time where you're frail. So that's what, that's one, just to say that it is unmeasured heterogeneity, and we don't know tons about frailty and how to kind of prevent it from happening, or how we can stall it, I think. So I think that the jury's out. So defining and identifying frailty, this is something I think nurses are contributing to. It's definitely not just one of these signs and symptoms that you see on the screen. So it's non-specific signs of illness in older adults is frailty. So any one of those things, immobility, instability, incontinence, could mean anything. They're just a symptom, and it's how do you actually successfully identify frailty? It's not as easy as identifying something like diabetes or COPD or hypertension. So it's sort of elusive. That's what I would say. So the CARES program running out of Fraser Health, and this is headed up by Grace Park and Annette Garm, is a community actions and resources empowering seniors. And so what it does is it is a targeted initiative where there's some case finding that goes on around who might be able to benefit from a health coach to prevent frailty and frailty-related healthcare use, because those people who are the most frail are the people who tend to go into the hospital, and then the costs are big. So what the CARES program does is it does case finding using the comprehensive geriatric assessment form, and it spits out for you a frailty index as a measure of the person's progress toward or away from frailty. And what it does is it has embedded the comprehensive geriatric assessment tool into the electronic medical record so that it can be done at point of service. And so this project, once the person has been identified as such, then there's a health coach that can, there's other resources that this program would particularly give them. In particular, health coaching, but also there's now programs being set up through community or organizations in terms of exercise kinds of programs and activities. So there's a recognition that we need to stem the wave of people who may hit the hospital. So in talking with the CEO there, it was really eye-opening, that there's a recognition that, it's not that we're trying to have cost savings so much as it is around not trying to overwhelm a system, so that there's a recognition that there needs to be some kind of more funding that probably goes into community-based services versus, we're going to take money from a hospital. So the hospitals are already overwhelmed, and we know that there's going to be more and more people that are older, and we want to make sure that they're healthy in the community and not needing to go into the hospital. So, this is the form. This is what it looks like. It's, you guys are nurses. You're familiar with forms and how these things work. So it's quite a lot of work to kind of fill it out. And what we're doing, the BCPHCRN, particularly through the CITSIN, is to try to So once this data is entered, we try to take it out on the back end. So to translate what this looks like for a clinician, because all you get here is you'll get the frailty index. So you'll just get a number, and we want to translate this into a visual format to view what frailty looks like for your patient panel in your practice. So this is just a slide to show you that, there's a whole bunch of different electronic medical records that exist out there. The ones in green are the ones that we extract data from in British Columbia. And so this is what I'm talking about in terms of spitting out that data in a form, and to have it come out in sort of what we call, I guess, a dashboard approach. So some of the electronic medical records have, quote, dashboards, but they're not created necessarily by medical or nursing professionals. So what we want to be able to do is take the frailty stuff and be able to have a report of what the patient panel looks like. So this is just showing you here some demographics of what this kind of looks like and the kind of information that you can then start to visualize coming out of your electronic medical record. And do they have these kinds of things in the hospital already? I'm assuming they probably have like dashboards. As a clinician, you can look at these kind of dashboards. Laura, you're shaking your head. Oh, I'm amazed. They don't have it, hey?
I don't think so. There are dashboards associated with other measures, but the frailty index per se has not been widely adopted, I would say, in the hospital setting.
Yeah.
The human type approach has been more embraced than the Rockford approach.
Right, yeah.
Schools of thought.
Yeah, I don't know. It's two opposing schools of thought there, but yeah. Yeah, Maura?
Sabrina, when you were mentioning the Inquire quality improvement tool, so I did a project a couple of years ago with emergency physicians and nurses and one of the lower hand health authorities, and basically it was for the same reason that the physicians and nurses were inputting all these data.
Right.
And we weren't getting any feedback at all on how that was really influencing their performance, but also patient outcomes. And they wanted to look at things like substance have the substance management program, so it's making a difference. So this was a couple of years ago, and I know it hasn't really changed, but there's no way for them to really extract data that's relevant to them so that it can help improve performance, and it's also not linked to any other part of the system.
Right, yeah. Wow, okay. Well, see, I keep thinking that the hospitals are so much farther ahead because it's so hard to do this in primary care. But so anyways, I think this is just gives you an idea of the kinds of things that you can look at. So when I show this to clinics, they're like, yeah, 30% of the population that we see are depressed, and that's why I'm like day in, day out, they're seeing people that are depressed. So that then just sort of reaffirms to them, okay, that this is happening. So this tool is really interesting because what you can do with this tool is the clinician at the point of care can re-identify for themselves. So when we extract data, it's all de-identified and it's all anonymized, it's all private, etc. But in this particular tool, we show the clinicians how they can re-identify, and they can use this tool for purposes of recall. So there's more analytics that you can do with this tool. So it's a pretty powerful tool. So this is the other tool. This is Inquire. This is, it stands for Interactive Quality Improvement Reporting Environment. And it really is sort of the baby version, if you will. So this is like this is the difference between, I would say, an Apple and IBM computer, or using SPSS versus SAS, right? So SAS, you need to know some programming, you have to understand it. SPSS is very Windows click and point. This is the click and point version, and everything in here is, everything that you can get in this one, you can get in the data presentation tool, but you can't re-identify. So in this one, you can see that the dark blue is the person, the middle blue color is the site, and then the gray one is the network. So it gives you an idea of what's going on. So in particular, this particular site sees more people that have osteoarthritis, for example. And this particular individual, which we call a sentinel, because remember it was funded first by the Public Health Agency of Canada, that they see a few more people with dementia than the rest of the network. And so anything that we're trying to report here has already gone through a fairly rigorous case definition validation. So we're not pulling the code on Parkinson's just from an ICD-9 code, for instance. We have a whole algorithm, and as I said, it's the informatics and analytics behind it that give you that particular diagnosis. But so, for instance, we had a master's student who was interested in looking at depression management in those with Parkinson's. And you can see that it was great to use the Pan-Canadian data set, because for any one practice, they're going to not be able to see many people with Parkinson's. So it's not something that they're seeing on a hugely regular basis in primary care, compared to something like your people that have hypertension or people who have depression. Okay, so then that's frailty and pairing with the BC PHCRN and CITSEN, and then this is an example where I'm doing some work and particularly trying to understand what's going on with primary care networks and patient medical homes. So this is some data that I pulled from, I went to the summit earlier last week, I guess. And this is sort of the newest stuff coming out of the government, the Ministry of Health, as well as what some of the innovative things that are going on in the different divisions of family practice. So nurses are now being hired in primary care clinics, and they're playing very interesting roles in terms of primary care. So, they do things like chronic disease management, and this is an infographic that is meant for physicians, right? Because many of the physicians in British Columbia are solo fee for practice. So they were trying to make a case for, okay, why would you want to hire a nurse, or why do you want to have a nurse in your practice, even if you're not the work person that's paying for them? And so what the sort of word on the street is amongst the docs is that, well, wow, it makes my practice more efficient. They can start to see more people. They have better attachment. They have more continuity of care with the patients because the nurses are there to support that. And also, lo and behold, it lowers their burden of work. So they are more satisfied with the amount of time that they can spend with their patients, and they also can see that their patients are getting more comprehensive care. They may be getting more time to discuss their problems and to sort of dig deeper rather than just to sort of a 10 to 15-minute visit. And so here's some different cases of different divisions of family practice. So in British Columbia, we have 35 different divisions of family practice. And basically the divisions of family practices are geographically similar practices in the same region. So for instance, there's a bunch of practices and they form the Central Okanagan division, or there's Kootenay Boundary, etc. So these different divisions have done different things. So Central Okanagan has hired a range of different nurses, LPNs, RNs, and NPs into the different practices to work in that particular division. Kootenay Boundary is using RNs to support the rollout and implementation of primary care networks. And Powell River has NPs that are now co-located with the family practice. And then White Rock, South Surrey also has a range of nurses that they are hiring. So one of the things that we're trying to do to support this work is some work that I've been involved in for the last 5 years, and that is looking at performance measurement and reporting of different indicators in primary care. And so we are creating regional level performance reports, but in the midst of creating regional level performance reports, we are giving back to practices, practice-based reports for the data that are valid. So for instance, they won't get any data from their patients who participated in the practice because it was only 20 patients in there. So we had a huge discussion about, whether we give it back or not, and it's not really valid, et cetera, et cetera. So, but this is what the different pillars are of the patient medical home. And so this is what primary care practices are trying to achieve. First is the patient medical home through these different pillars. And then together, these different patient medical homes will link up with the primary care networks. Okay, so I don't have a slide on the primary care networks, but essentially the primary care networks describes a situation where the health authorities are partnering with different patient medical homes in that particular area. So like I said, in Interior Health Authority, there'll be different primary care networks that are forming now. So Kootenay Boundary is going to form a primary care network, and then there'll be a different primary care network in South Okanagan. So there's those kinds of things. So the kinds of data that we're giving back in a regional portrait draws on some patient data, as well as organizational data and et cetera. So the patient data, this is kind of what it looks like. That we collected data in Eastern Ontario, Fraser East, and Central Zone in Nova Scotia. And you can see that the blue line is where Fraser East is sitting in British Columbia, and the orange one is on Eastern Ontario, and the gray one then is Central Zone. And Eastern Ontario seems to be having the best scores, if you will, in terms of patient-reported experiences. Most of them are looking similarly across equity orientation, and there's probably the most difference in terms of self-management support. So we also did some case studies in this work, and we wanted to understand what the innovations in primary care were. And so one of those innovations was innovations in implementing interprofessional teams. So we have done a bunch of work to understand what that looks like across the different regions, because you can't ever report on performance metrics without first understanding what the context looks like. So you can see that in Ontario, clearly they have been working on interprofessional teams and team-based care for quite a while, since 2004. And in British Columbia, we are just at the beginning of that journey, and then Nova Scotia is sort of in the middle. And so here's some data coming from the organizational survey, and it's looking at, this is one of these pillars in the patient medical home, and it's looking specifically at team-based care. And so this one, essentially, I've circled in purple, Ontario. So Ontario has the most different composition of people in terms of team-based care. Now the numerators are slightly different, but they still have more nurse practitioners and nurses working in team-based care kinds of models when you compare that to either Nova Scotia or Fraser East. And then we also collected team climate inventory scores. So this is looking at team effectiveness. And the purple one I'm just showing you here, that the participation in the team, this is reported by the team members themselves, is lowest in British Columbia, in Fraser East, when you're comparing it to either Eastern Ontario or Central Zone. So we're just at the beginning stages of sort of putting all this data together. So here's another slide looking at practice integration and what's going on in terms of formal and informal arrangements with other primary healthcare clinics. And the thing that I would point out here is that for planning services offered, that there is lots of going on in terms of the BC region, in terms of planning services, and there's less going on in terms of exchange of resources. So for instance, loans of professionals. And this data was collected probably now 1.5 years ago. So I would expect if we were to go back in there now, or even in 6 months, once there's been more rollout of primary care networks, et cetera, that this would look differently. But you can see that they're not working tons outside of their own practice. And then finally, the other contribution is to curriculum. And so these are the primary care network attributes down the side. Advice and information, comprehensive primary care, and culturally safe and trauma-informed care. And this is where nurses, and particularly those at UBC, are going to be contributing a lot. And so I have things in here. I think it's particularly interesting around the pillar of the attribute of the patient primary care network, that they talk about culturally safe and trauma-informed care. And the nurses in this program are some of the leaders in that. And so, Colleen Barco, Annette Brown, they have done some work looking at equity-oriented processes in healthcare. And there's a toolkit that we're going to be drawing on in terms of the curriculum. And then there's also some other things that are going to go on in terms of the different other attributes. And you can see that in our School of Nursing, we teach the nurses, both the undergraduate nurses and nurse practitioners, nursing specific competencies. Well, actually all graduate nurses, particularly around relational practice, reflective practice, population health, social justice. So these are some of the different kinds of things that we are going to be contributing to. Basically, I think it is the first course in primary care at the undergraduate level in British Columbia. And I don't know, Elizabeth, if that's right or if I'm mistaken on that one, but I'm
Nope,
sure
you're right.
The other schools will follow, but we are going to be ahead of the game, maybe for a semester. But anyways, we get our first cohort of students running through this program, and Elsie Tan is heading this up for UBC, School of Nursing, and I'm going to help out with it. But anyway, so I think there's a lot to draw on in terms of the evidence and the theory, and also we're sort of at the beginning of what nurses are doing in primary care in British Columbia at the undergraduate level. So obviously the nurse practitioners have been around a bit longer. So yeah, and we hope to see students working, having practicum placements with nurse practitioners that are out there, because nurse practitioners are now more established in primary care practices, but also in some other areas as well. And that's that's it. So there's time for question and dialogue. Mm-hmm.
I have a question. So, how do primary care clinics get connected to the networks?
Yeah, how do they how do patient medical homes or primary care clinics get connected to the network? So there's a process which the Ministry of Health is going through right now to give the primary care networks some startup funding. Like I think it's like $150,000 to sort of start to move towards a primary care network. And there's certain kinds of things that they want you to implement. And there may be someone on the WebEx or the GoToMeeting from the ministry if somebody would like to answer that question. Maybe Barb, I don't know if you know, because I don't want to speak for the ministry. How do you, can I just unmute people or can they unmute themselves?
Just click the all. Oh, yeah, I did. Yeah, it's fine.
I don't know if Barb's there. She's. Yeah. So they have a process in the ministry, and there's an application form that different primary care networks can fill out. So it's like a grant in the sense that, you put your team together to say there's a primary care network, and then you apply for that money, and then they will do their best to figure out, okay, who's going to come online. So I think there's a few of them, but the ministry person said that they were fairly overwhelmed with what was going on because there's been a lot of people that want to get online. Yeah.
Barb said she didn't have an answer for that.
Oh, okay. Perfect. Yeah, Wendy?
Sabrina, great presentation. Thanks for that. I was looking at the various pillars you were talking about, and if you had to make a comment about where the bulk of the attention is going, would it be around chronic disease management and frailty, or would it be around health promotion? I'm just interested in how those varying priorities would be. Not that the two are mutually exclusive, but.
Yeah. So when I looked at so there was a list that came out, like some of the docs presented a big list in terms of the quote, the nurse in practice model.
Yeah.
And a lot of those things are actually more oriented towards, I would say, health promotion kinds of activities. But I think it's both chronic disease management and also more the health promotion activities. So yeah, how that kind of plays out in a practice, I'm not sure. It's probably going to be variable, but yeah, I don't know if that helps or not.
Yes. I was just thinking about the links that you were talking about with public health and how, the various levels of expertise could be leveraged, that's all.
Yeah. And I fully expect that, and it would be interesting if we had someone here from Northern Health, because Northern Health basically took all of their public health nurses and stuck them into sort of primary care networks or patient medical homes so that public health could be really much closer to what primary care is doing. And so it would be interesting to hear what they have to say. Elizabeth?
That intrigues me, but also concerns me because it raises the question of, are then public health nurses being tapped for strictly one-to-one primary health care rather than actually the full scope of public health nursing practice? So are they sort of moved into that? That's been one of the concerns I know North Shore Public Health here within Vancouver Coastal has expressed some concern about that. Already a number of their child and youth nurses are spending most of their time in youth clinic, which is a strictly one-to-one practice and not necessarily doing things like school health nursing or the community immunization clinics or the broader sort of health promotion activities that are at a population level. So that would be my only
Yeah,
concern is,
yeah.
are they moving to primary care and away from public health?
Yeah, so yeah, that's really interesting. I don't know what's going on in Northern Health on the ground. And my sense of it is that they've moved more towards practice population management. But that you're right. I think as they move towards PCNs, where there's a working with the health authority and the divisions of family practice, that they really try to keep the population health focus of the health authority versus practice population, right? So all of a sudden we have individuals, then we have nurses coming in and looking at sort of the practice population. So we're asking them to stretch what they're used to doing. And then we have the population health stuff, which is seemingly untangible. Like you can't, it's hard to measure and, you know, all that kind of stuff. And so then the question is, how do you marry those things together? So I think they're still doing probably the surveillance pieces and the epidemiology that they probably do, but it's more around like the population health, the other kinds of things.
Broader programs.
Yeah, so the broader program, and I think we need to try to help them articulate what those broader programs are. And you probably know more about that than I do.
Yeah, it's an interesting thought, and I'm, you know, as I'm looking at and thinking about how where nursing fits within primary health care and primary care clinics, as well as public health and the sort of the full scope of practice, from home health care to
Right.
School nursing to the epidemiological and health planning kinds of things, all the way to also, you know, that one-to-one health education that happens in a clinic. It's an interesting, my one concern is that while I think it's really, really excellent that family practice is finally getting on board and recognizing that there are significant rules for nursing in primary health care that other parts of the world have already sort of sorted out for years. That we're not in the process losing other clear and important nursing roles within the health authorities because they're just, you know, devolving into primary care nurses and not necessarily retaining the full scope of where nurses are needed.
Yeah. Yeah, no, I think that's good. Laura?
Sabrina, maybe piggybacking on that is even, I know you said that for you the definition of primary care is really at that point of care delivery, but there are those issues around the differences between primary care and primary health care, and how we even educate our students about those differences that may exist in kind of a medical model versus a nursing model.
Yeah,
I don't know if you want to say
absolutely.
something about that, because it's not my area. I've just been reading more about that, how there are those, I guess, ideological differences.
Yeah, well, I mean, that's a whole kind of debate to kind of get into, but certainly.
Can you repeat the question?
Oh, so the question is
Even how you name it, so calling it primary care versus primary health care.
yeah, primary care versus primary health care, and the differences, and to be cautious of the sort of underlying theoretical assumptions that maybe drive the sort of the different models forward. Yeah. Yeah.
I just worry about nurses going into medically driven primary care clinics where they are there to do what the physician may tell them to do, and they lose some of that autonomy around what we know to do is kind of the bigger picture.
Yeah.
Around social determinants of health.
Yeah, and I think that happens, and I think it also happens the other way, that the nurses and the nurse practitioners, because of their training, are are changing the fabric of what the practice actually does and is. And so I think that that's definitely, something that we want to try to encourage. I think it's hard, right? Because who are they drawing in right now for nurses working in primary care? It's mostly those people from acute care. And so even those nurses from acute care would have a very different view of primary health care. And so, that's why I say I'm looking at it more from a place and a service delivery versus a philosophical stance. Because you could say you're doing primary health care and working in the critical care unit. And I'm not sure there's many nurses that do that either. So I do think it's our responsibility to be teaching that for all of our programs. And it's really kind of our, the perspective that we need to kind of keep on hammering home. And I think there's a lot of things that we can be adding in terms of the different kinds of values and some of the things that we're really strong in the School of Nursing. I think that will help, right? And I think in the nurse practitioner program, you're probably teaching some of these kinds of, intersectionality theory and trauma-informed theory and, those kinds of things. Lindsay, what do you think? You just graduated. What are you thinking about all this?
I guess a lot of it is all covered in curriculum as well. Like you were mentioning that we have a relational practice course. There's definitely been lectures on trauma-informed care and everything like that. And I don't know. I think that there is a good distinction made between primary care and primary health care. Definitely covered in our community nursing versus. I don't know how that's changing the curriculum, but I would say that it's covered pretty well with the program I do.
Yeah. Well, that's good. We'll definitely be looking at those because it's not that we're throwing everything out. It's just that we're going to reorient it a bit and to add some other pieces to widen up the different placements. Yeah.
Do you think now that if we're introducing primary care courses in the curriculum, that it's going to draw new grads who tend to be drawn more towards areas that are acute in nature to work there, and so their transition to primary care is more difficult? I mean, I've personally experienced that. I've tried getting to public health, and I wasn't able to because I had too much surgical experience. I'm just wondering, what do you think? I know it's kind of a premature question, but do you think people will be more drawn to work in primary care from a nursing standpoint to fill those roles where they're needed with the new curriculum coming in?
So the new curriculum, it's not the be-all end-all. It's one course. And then they can do their preceptorships or whatever. I do think that, there's still 80% of our nurses work in hospitals.
Yeah.
And, there hasn't really been a lot of room for nurses to be working in other places besides public health. And there's some that work in home care, et cetera. So I think we should see a shift if there's more opportunities. Because I don't think everyone wants to work in the hospital. And certainly we know that people over time, they get really tired of the shift work and working in hospitals and stuff. And then they kind of want to transition and change. And I think what our curriculum and course will do, hopefully, is open up the realm of possibilities. And I know that the divisions of family practice and the ministry is really excited about what we're going to be doing because we are going to start to train sort of the next generation that will be really prepared to be out there in practice.
Sabrina, I just wanted to add to that in the new curriculum, we're also putting more focus on team-based care delivery.
Yeah,
and
right.
What does that look like?
Yeah, that's right. Yeah, that's exactly right. And we have a lot of resources at UBC to draw on. We have the innovation unit through Morgan Price in the Department of Family Practice, and I'm part of that unit. So they sit in particular departments and stuff, but it really is meant to be interprofessional. So yeah, but I'm recognizing the time, so thank you all for coming. So very